Good evening, everyone. After two scintillating sessions, we are now starting the third session, that is the tissue protection. And to moderate this session, we have none other than the chief editor of our Annals of Cardiac Anesthesia, Dr. Prabhat Tiwari. And along with, we have got very senior person, Dr. Gopinath, Dr. Dheeraj, Dr. Rupa, and Dr. Ashish. I request Dr. Prabhat Tiwari to start the session and conduct the session, please. Thank you.
Good afternoon, ladies and gentlemen. This session is on tissue protection, and I will invite Dr. Gopinath. He is from ESIC Medical College Hospital and Super Specialty Hospital, Hyderabad, to introduce Dr. Anandi Arul. I'll invite Dr. Dheeraj Arora, Senior Consultant from Medanta Medicity, Gurugram, Delhi, to introduce Dr. Manoj Kamal. And I invite again Dr. Rupa Sridhar from, she is Professor Head Cardiac Anesthesia, Sri Chitra Tirunala Institute of Medical Sciences from Trivandrum, to introduce Dr. Sandeep Gare. And I also welcome Dr. Ashish Amatya from Shahid Gangalal National Heart Center, Kathmandu. He will reserve his comments to come at the end. Over to you, Dr. Gopinath.
Hello. Yes. It's my pleasure to invite Dr. Anandi Arul. She is from the G. Kuppuswamy Naidu Memorial Hospital, Coimbatore. She is the Chief Consultant Cardiac Anesthetist there, and she'll be speaking to us today on lung protective ventilation and postoperative pulmonary complications in cardiac surgery. I request Dr. Dheeraj Arora to introduce the next speaker.
Hi, good afternoon all. Now I invite my friend Dr. Manoj Kamal. He is additional professor at All India Institute of Medical Sciences, Jodhpur. Now he will be speaking on myocardial protection during cardiac surgery and update. Now I invite Dr. Rupa to introduce the next speaker.
I invite Dr. Sandeep Gare, who is a consultant cardiac anesthetist in Sunshine Hospitals, Hyderabad, to speak on neuroprotection in aortic surgeries. Dr. Sandeep is a DM in cardiac anesthesia from Sri Chitra Tirunal Institute.
Well, I will, thank you, Dr. Rupa. I will now request all the audience to, whenever you have questions, please put them on the chat box, and we will take from there at the end of the lectures. Now, I request all the presenters to begin their lectures. The lectures, please.
Good evening. At the outset, let me thank the IACTA for giving me this opportunity. The topic given to me today is pulmonary complication and lung protective ventilation in cardiac surgery. Lungs are so closely associated with the heart that it takes a big hit during cardiac surgery, be it off-pump or on-pump procedure. The resulting dysfunction causes pulmonary complications in the postoperative period that adversely affects patient outcome. It increases morbidity, increases in-hospital mortality by about 4-fold, extends ICU stay and hospital stay, and resulting in a huge economic burden on the patients and their relatives. Are these postoperative pulmonary complications common? Yes, the overall incidence being 10 to 25% in cardiac surgery. The complications are multitude, and on top of the list, we have atelectasis, the incidence of which is about 30 to 72%, followed by pleural effusion, pneumonia, bronchospasm, and ARDS. The pathogenesis of pulmonary complications are multifactorial. The cardiac surgical insult and the trauma caused by ventilation activate lung inflammation with the resulting release of inflammatory mediators which cause lung injury, resulting in clinical hypoxemia. All this will lead on to pneumonia and ARDS. There are various factors that are implicated in the pathogenesis of pulmonary complications. The surgical factors being sternotomy, the harvesting of internal mammary artery, which necessitate pleural dissection, hypothermia for myocardial protection, transfusion of blood and blood products, and of course, cardiopulmonary bypass. With the onset of cardiopulmonary bypass, the blood is exposed to the extracorporeal circuit, and all this results in inflammatory mediator release. Apart from the surgical factors, anesthesia and patient-related factors also play a role in the pathogenesis of pulmonary complications. As soon as the patients are anesthetized, 90% of them have CT demonstrable atelectasis. This is because of a reduction in FRC with the induction of anesthesia and obtaining a supine position. Many of the surgical patients have pre-existing lung disease. They may be chronic obstructive pulmonary disease patients, or they may be heavy smokers, or they may have LV dysfunction. All these can lead to postoperative pulmonary complication. So there are a lot of measures which can be implemented to prevent postoperative pulmonary complication. This can start right from preoperative preparation to the postoperative period, where you reduce the duration of mechanical ventilation, cause early mobilization and early discharge from ICU. But as cardiac anesthetists, our focus should be on minimizing intraoperative lung injury by protective lung ventilation and open lung ventilation. So how does protective lung ventilation is beneficial? It prevents alveolar overdistension. It limits the increased airway pressure, thus preventing barotrauma, prevents recruitment and re-recruitment of lung units, that is atelectasia. All these will result in a reduction in the systemic release of inflammatory mediators, and thus reducing biotrauma. The ventilation strategy that have been accepted is protective ventilation, and this I would call is an era of low tidal volume, and the other interventions being using of minimal PEEP of at least 5 centimeters of water, and also by thereby avoiding zero end expiratory pressure. Recently, the focus is on limiting the driving pressure to less than 16 centimeters of water. The driving pressure is nothing but the difference between plateau pressure and the total PEEP. Open lung ventilation, that is using higher PEEP, more than 8 centimeters of water, recruitment maneuvers, and ventilation on cardiopulmonary bypass have also been investigated to prevent postoperative complications. I'm sure all of you are familiar with this landmark study published in May 2000 by the ARDS network group, where the investigators looked at low tidal volume ventilation and compared with the traditional tidal volume in patients with ARDS. And here they have clearly shown a mortality benefit. Influenced by this trial, many investigators have tried to use low tidal volume in normal patients undergoing surgery. And in 2013, the Improve Study Group published this well-conducted study where they looked at 400 patients and divided them into 2 groups, the lung protective ventilation group and the non-protective ventilation group. And they clearly showed that the patients with lung protective ventilation had reduced pulmonary complication of about 10.5% as opposed to 27.5% in non-protective ventilation. So though this was on abdominal surgery, this paved the way for various other studies. And what about in cardiac surgery? This was a systematic review which was published in 2017, where the authors identified 18 RCTs involving 1,470 cardiac patients. And of these 18 trials, there were only 5 RCTs which compared the intraoperative protective lung ventilation bundle with conventional ventilation. But all these only looked at inflammatory mediators and lung function, and no trial looked at outcomes. What about the postoperative trials? They identified 13 studies, and these studies also looked at oxygenation indices and respiratory mechanics and did not look at patient outcomes. So, since the trials were not large and not powered for clinical outcomes, the authors could not make any best ventilative practice recommendation. But what they said was that all patients undergoing cardiac surgery should have a tidal volume of 6 ml per kg, a PEEP of 5 centimeters of water, and should limit the FiO2 to less than 0.5, aiming for a saturation of about 94%. What about driving pressure? Recent studies have suggested that the benefits associated with low tidal volume and PEEP are mediated by driving pressure. As we already discussed, driving pressure is defined as the plateau pressure minus the PEEP. So this study, which was published in Anesthesiology in 2019, was an observational and retrospective study where 4,690 cases of cardiac surgical patients were reviewed, and the authors found an incidence of about 10.9% of postoperative pulmonary complication. They also tested association between bundled intraoperative protective ventilation strategies, such as a tidal volume below 8 ml, modified driving pressure to less than 16 centimeters, and PEEP equal to or greater than 5 centimeters of water on postoperative outcomes. And what they concluded was that an intraoperative lung protective ventilation bundle was independently associated with reduced pulmonary complications after cardiac surgery. And of the 3 protective ventilation strategies that they looked at, they found that the driving pressure of less than 16 centimeters of water was independently associated with reduced PPC. As we have already discussed, the atelectasis or lung collapse is a primary event which leads on to a cascade of events resulting in lung injury. And there are many debate as to whether open lung ventilation using high PEEP, that is PEEP more than 8 centimeters of water, recruitment maneuvers, and ventilation during CPB will have an effect on postoperative complications. This debate led to the origin of this PROVEX randomized clinical trial, where the researchers studied the effect of open lung versus conventional perioperative ventilation strategies on postoperative pulmonary complications. This was a randomized pragmatic multicenter controlled trial looking at 488 patients on CPB. They divided the patients into 2 groups, a conventional strategy, ventilation strategy versus open lung strategy. All patients had a tidal volume of 6 to 8 ml per kg. The respiratory rate was adjusted to obtain EtCO2, or the entitled carbon dioxide, of 35 to 45 millimeters of mercury. The FiO2 was adjusted to get a SpO2 of greater than 94%, and all patients had an IE ratio of 1:2. But in the conventional group, the PEEP was set at 2 centimeters of water, both in the intraoperative as well as in the postoperative period. They did not have any ventilation on CPB, and there was no recruitment maneuvers, as opposed to the open lung ventilation group, where the PEEP was set at 8 centimeters of water, and patients were ventilated even on bypass with a tidal volume of 3 ml per kg, PEEP of 8 centimeters of water, and an FiO2 of 0.4. And the recruitment maneuvers were carried out at 5 points with a CPAP of 30 centimeters of water for 30 seconds. And what did they find? It was very surprising to find that there was no difference in postoperative pulmonary complication between the open lung ventilation and those assigned to the conventional ventilation. And so the authors very sadly concluded that the perioperative open lung ventilation, including ventilation during CPB, does not reduce the incidence of PPC as compared to the usual care. So what should we be doing? So all patients undergoing cardiac surgery should follow a protective ventilation bundle with a low tidal volume of 6 ml per kg, with a PEEP of 5 centimeters of water, with an FiO2 of lowest FiO2, maintaining a saturation of about 94%, and limiting the driving pressure to less than 16 centimeters of water, and routinely avoiding the use of high PEEP recruitment maneuvers, and not ventilating the patients during CPB. So to conclude, the cardiac surgery does cause lung injury, and that may result in postoperative pulmonary complications. And the incidence of PPC in our unit should be researched and studied, and so that protective ventilation bundle can be followed to reduce postoperative pulmonary complication. Thank you.
My topic is myocardial protection during cardiac surgery, an update. And first we have to know what is the myocardial protection. In cardiac surgery, we have to provide bloodless and motionless surgical field during the surgery, and by this bloodless field, it is always there is some kind of myocardial injury. If heart is good in shape, that it is very well tolerated, but it cannot be tolerated in bad heart, or especially when myocardial dysfunction is of a long duration. So whenever there is imbalance in myocardial delivery and requirement, there is some sort of myocardial injury. Although in myocardial ischemia, it is unplanned, but in cardiac surgical, this injury we have planned, and it is of global in nature, and start after application of aortic close clamp. So whenever there is inadequate myocardial protection, there is increased chances of acute myocardial ischemia, arrhythmia, ventricular dysfunction, and patient might have cardiogenic shock, which may lead to increased perioperative mortality and morbidity in cardiac surgical patients. So these are the changes. Whenever there is ischemia is induced in the heart, there is a decrease in ATP, adenosine, glycogen storage, and there is development of lactic acidosis and increase H-ion, which these injuries are further accentuated by the calcium overload in the cell. And reperfusion, when their blood is again given to the ischemic injury, it may lead to hyperemia, cell swelling, or ultimately normalize the pH or decrease lactate. Regeneration reperfusion may also lead to development of free radical generation. There is alteration of beta adrenergic signaling transduction, or there is activation of the complement cascade pathway. So whenever there is acute ischemic dysfunction, it usually of short duration, it is usually reversible. Where it may be stunning or hibernation, which is partially reversible, or in prolonged time when there is ischemia or necrosis, it may lead to necrosis or apoptosis. So strategies, what are the strategies we have to look into cardiac surgery? These all strategies are applicable in all like in pre-operative, intraoperative, and post-operative period, and we have to take care of the balance between the demand and supply ratio. So historical part, Bigelow first started myocardial protection in 1950, way back 1950s, and it by the topical cooling and systemic hypothermia. After that, Melrose given the hyperkalemic cardioplegia solution, and this provide the myocardial protection. After that, blood is used for cardioplegia, potassium concentrates it reduced by the 20 millimole, and some cardioplegia solution is derived by the breast needle and Hertz by St. Thomas solution. But there are a lot of modifications are available, but there is no full proof of the myocardial protection. So hypothermia and cardioplegia are two main pillars for the prevent the myocardial injury during the cardiac surgery. They lowers the metabolic requirement, decreases the oxygen requirement, and promote electromechanical quiescence. So this is a table showing when their heart is full and beating at 37 degree, it requires 9 ml per 100 gram of per minute. But when we are using cardioplegia, it drastically reduce the oxygen requirement up to 1.8 ml. So it protects the heart. The various type of cardioplegia solutions are available in the market: blood and crystalloid cardioplegia. And crystalloid cardioplegia is further divided according to the composition into the intracellular and extracellular component, and it is many additives are also added in the cardioplegia to provide the substrate to the heart. So this is a review article published in 2003, and according to that blood cardioplegia is superior to cold cardioplegia, and adjunct the glutamate, aspartate enhancement, and antioxidant supplementation, nitric oxide donor are effective. Pharmacological preconditioning by the sodium hydrogen exchanger inhibition and gene therapy need to be addressed in the future in myocardial protections. There is a review article which published in a European journal, warm versus cold cardioplegia for the heart surgery, and they compared the beneficial and harmful effect of these type of cardioplegia. There is less release of cardiac enzymes CPKMB and troponin in warm blood cardioplegia in compared to cold cardioplegia, but there is no significant clinical difference in significant clinical events. Cold blood versus crystalloid cardioplegia, another meta-analysis published in JCVA, and according to that, cold blood cardioplegia reduces perioperative myocardial infarction when compared to the cold crystalloid cardioplegia, but overall there is no difference rate of spontaneous sinus rhythm, mortality, and AF and stroke volume were observed. But lots of studies are in favor of using blood cardioplegia, especially in patients with long cross-clamp time or in patient of low ejection fraction. They prove that these are the efficacy, they are more effective myocardial protection strategy. Hot shot is mainly used during reperfusion. Hot shot enrich the heart with the high energy bond, and it also act a buffer and free radical natural scavenger. So it is a commonly used technique during the reperfusion. Some cardioplegia additive like adenosine, aspartate, glutamate. Adenosine causes instant arrest, while aspartate glutamate provide the substrate, insulin, and glucose. In long term, fail to show the benefit in high risk surgery. Beta blocker, other antioxidant, monoclonal antibodies, filtering of leukocyte during reperfusion, and other L-arginine, L-cysteine, nicorandil are other cardioplegia additive which are used with the cardioplegia solution. Dillido is nowadays commonly used. Initially, it come up with the come in the pediatric heart surgery, but because of immediate recovery and fewer rhythm disturbance, it is also used in the adult cardiac surgery. It contains high amount of the lignocaine. This is the myocardial protection. Compare the Del Nido versus blood in adult cardiac surgery, and according to that, Del Nido provide equivalent myocardial protection, efficacy, and surgical workflow, and it is safe or alternative to blood cardioplegia in the valve surgery, CABG or valve surgery. So, few words about myocardial ischemic preconditioning. It started way back in 1986 by the Murray, and it decreases the apoptosis, infarct size, and reperfusion associated arrhythmia. And volatile anesthetics is also used for the preconditioning, known for the preconditioning since long back. They decreases the myocard enzyme level, troponin, CPKMB, and BNP, and they decrease the free radical production, improve the cardiac indices in postoperative period with minimal inotropic requirement, and they also facilitate early extubation and less intensive care stay. So in 2011, ACC and AHA recommend that volatile anesthetic is a grade 2 level of evidence for the CABG surgery. But this is article published last year, 2019, preconditioning in anesthesia, where we are. There are many types of preconditioning methods are used, but is according to this, retrograde remote ischemic preconditioning is the future of cardioprotection. And MyReact trial, which is published in NEGM in 2019, that compare the volatile effect in the patient of CABG. It is single center, and it has around 5,400 patients. It is around 64% of patient is on pump surgery, and this trial is stopped interim after the interim analysis, and according to that, patients undergoing elective CABG anesthesia with volatile agent did not result in significantly fewer deaths at 1 year than the total venous anesthesia. This is another meta-analysis published which compared the volatile versus TIVA in patient with CABG. Primary outcome is also 1 year mortality, and it conclude that use of volatile anesthesia during CABG is not associated with reduced risk of mortality and compared to TIVA, but evidence are insufficient and inconclusive, and future large scale RCT is required to clarify the issue. Then another meta-analysis published in anesthesiology, volatile anesthetic versus propofol, and according to that, in adult patient undergoing cardiac surgery with CPB of volatile anesthetic is superior with regard to long-term mortality as well as secondary outcome. So this is an editorial published in JCVA in last year, myocardial preconditioning with the volatile anesthetic, goodbye to all, because they also compared TIVA versus volatile anesthetic, and in both group there is 2.8 or 3% reduction in mortality. So volatile anesthetic providing no protection against the adverse outcome after CABG, but they are associated with increased mortality in long term. But this conclusion we have to taken care, because these are retrospective. There is substantial variability in hospital practices, and there is difference in population genetics and social demographic profile of the patient. These are the future trends of reperfusion management: endothelin receptor antagonist, endothelin-1, erythropoietin, interleukin-1 receptor antagonist, glucagon-like peptide analog, nitroprusside as a nitric oxide donor, cyclosporin A inhibitor, C5a antibody, elafine, stem cell therapy or angiogenic factor. These are the future trends in the reperfusion management. To summarize, myocardial protection is more important in sick and elderly patients. Del Nido is equivalent to blood cardioplegia in adult cardiac surgery. TIVA and volatile anesthetic agents are equally effective in on-pump CABG surgery, but volatile anesthetic is preferable in on-pump CABG patients. Thank you all for the patient listening, and I also invite for our national conference at Jodhpur in next year for the same. Thank you.
Good evening. It's an honor and privilege to be here today. I thank everyone responsible for this. Today I'll be speaking on neuroprotection in aortic surgeries. At the onset, I would like to declare that I do not have any interest. Aortic arch surgeries are among the most technically demanding ones as they involve direct manipulation of the head and neck vessels. This may require interruption of the natural cerebral perfusion at times. Hence, there is a very high risk of neurological injury, and therefore the need for neurological protection is substantial. To understand why the brain is so prone to injury, we need to realize that it has extraordinary energy requirements. Although it accounts for only 2% of the body weight, it receives nearly 15% of the cardiac output and utilizes 20% of the available oxygen at rest. Most importantly, it does not store any glucose, and therefore during ischemia, there is rapid depletion of ATP. So this high metabolic demand, coupled with its dependence on aerobic metabolism, makes it more prone to injury. Ischemia is a primary mechanism for neurological injury in arch surgeries. There are two major reasons for this. One is global hypoperfusion, which occurs during periods of circulatory arrest or inadequate protective strategy, or there could be because of cerebral emboli in the form of particulate debris or that of platelet and fat, or it could be air embolism from the open arch vessels. Historically, neurological injury has been classified as permanent neurological dysfunction. It could be stroke or coma, or it could be temporary neurological dysfunction. It could be transient neurocognitive dysfunction, such as confusion or delirium. But whatever may be the form of neurological injury, it has a devastating effect on the overall outcome of the patient with respect to mortality or length of stay in ICU, etc. As a result, strategies have been developed to minimize this neurological injury. Basically, injury occurs because there are periods of decreased supply to a very metabolically active tissue. So the strategy is that either we decrease the demand by hypothermia or we maintain a continuous supply by some perfusion strategy. All this could be supplemented by using some pharmacological adjuncts. So coming to hypothermia, hypothermia reduces the molecular motion, the enzymatic activity, and thereby decreases the cerebral metabolic rate. It is the most effective means of reducing the cerebral metabolic demands. McCallum found that cerebral metabolism decreases by almost 7% for every 1 degree fall below 37 degrees centigrade. This provided us a starting point in calculating the estimated safe arrest limit, which is found to be approximately 5 minutes at normothermia. When you cool the patient mildly, you could get up to 10 minutes of safe arrest time, and at moderate hypothermia between 20 to 28 degrees centigrade, the safe arrest limit would be around 20 minutes, and in deep hypothermia between 14 to 20 degrees centigrade, we could have a safe arrest limit of around 30 minutes. Beyond 14 degrees, this protection is minimal and could actually aggravate neurological injury. So how exactly do we go about deep hypothermic circulatory arrest? We cool the patient using a high-flow cardiopulmonary bypass circuit, and the rate of cooling has to be very slow and gradual. The temperature difference between the perfusate and the patient core must be less than 10 degrees centigrade. This is important because large temperature differentials lead to non-uniform cooling, and this could lead to areas of warm, vulnerable brain. The depth of cooling is controversial. However, electrocortical silence or a jugular venous bulb saturation of more than 95% signify maximal cerebral suppression. So this could be the physiological endpoint for cooling. It is generally between 15 to 20 degrees centigrade. And once we reach this, we generally cool for another 5 to 10 minutes, and then we initiate the circulatory arrest. How much time do we have is dependent on various factors. However, in general, at 15 to 20 degrees centigrade, we have approximately 30 minutes. In addition to systemic hypothermia, topical hypothermia by packing the head in ice and also using cooling caps or helmet, we can minimize the passive warming of the head and promote uniform cerebral hypothermia. The major concerns are that it could cause some thermal injury or retinal ischemia, and it may also interfere with our cerebral oximetry monitors. Despite the almost ubiquitous practice of topical head cooling, there is limited evidence of its efficacy in clinical application. As with cooling, rewarming is also very important. Rewarming increases the cerebral metabolic rate, and this could aggravate the neurological injury. Therefore, rewarming should be gradual by keeping less than 10 degrees centigrade difference between the perfusate and the core temperature. And it should be facilitated by using vasodilators, treating metabolic acidosis, and we should terminate rewarming when we reach a temperature of approximately 35 to 36 degrees centigrade. It is important that we avoid cerebral hyperthermia. The advantages of hypothermic arrest are that it provides a bloodless and motionless operative field. It is technically simple and there is no additional manipulation of the aorta. It has been found that it is the single most important intervention for preventing neurological injury during arrest. However, the principal drawback of hypothermic arrest is the time constraint placed on the surgeon. We are just giving him close to 30 minutes. And if you go beyond that to 45 minutes, the stroke rate increases from 4 to 13%. And beyond 60 minutes, you're almost going to have a patient with some form of permanent neurological damage. Also, since we need to cool and reform the patient very slowly, we are going to prolong the cardiopulmonary bypass time. And so we could have some pulmonary renal dysfunction. We all know that we store platelets at close to room temperature because platelets do not tolerate hypothermia well. So now when we are deliberately going into deep hypothermic arrest, we could expect some amount of platelet dysfunction. This could lead to some coagulopathy and bleeding in the postoperative period. We have seen that despite the relative safety of DHCA, there is a finite time limit before irreversible CNS damage occurs. So, to prolong the circulatory arrest time, cerebral perfusion strategies have been developed. The first one is the retrograde cerebral perfusion. Here, first the SVC is cannulated and slugged, and then the patient is cooled to the desired temperature. And then when we want to initiate the circulatory arrest, we clamp the arterial side, we clamp the venous side, and also the inferior vena cava cannula. And then this loop is opened, and cold oxygenated blood is then perfused at 10 to 18 degrees centigrade into the SVC, into the cerebral venous system. We need to know that the perfusion pressure must be less than 25 millimeters of mercury to prevent any cerebral edema. The patient is generally put in 10 degrees Trendelenburg to decrease the risk of cerebral embolism. The advantage is that by providing a continuous perfusion to the cerebral parenchyma, we could promote greater degree of hypothermia and also provide some metabolic substrates. The major disadvantage is that there is a risk of cerebral edema. Also, it could increase cerebral venous resistance. The other perfusion strategy is the antegrade cerebral perfusion. Here, one or more of the brachiocephalic vessels or the axillary artery is cannulated, and then it is connected to a separate circuit with a dedicated heat exchanger. After cooling the patient and going into circulatory arrest, oxygenated blood is taken and cooled to 10 to 14 degrees centigrade and perfused into the cerebral vessels at a rate of approximately 6 to 10 ml per kg per minute. Usually, unilateral antegrade cerebral perfusion via the right axillary artery is a popular technique. This assumes an adequate circle of Willis and therefore both the hemispheres are getting perfused. But this does not occur in nearly 15% of the patients. So bilateral antegrade cerebral perfusion, wherein you use another cannula into the left carotid artery in combination with the one with the right axillary artery is used. So this seems more physiological because simultaneously you're going to perfuse both the cerebral hemispheres. However, it carries the risk of additional manipulation of the head and neck vessels. Now, with antegrade cerebral perfusion, wherein the blood flow to the brain is maintained continuously, do we actually need to go into deep hypothermia? So some surgeons have used moderate hypothermic circulatory arrest. So here we cool the patient only to 20 to 28 degrees centigrade and then go into circulatory arrest. And during this period, the brain is perfused by antegrade cerebral perfusion. So by reducing the overall degree of hypothermia, we're reducing the total bypass time, and hence we're going to decrease the end organ dysfunction and coagulopathy. But the major concern over here is that whether the spinal cord and viscera are adequately protected with this moderate hypothermia. The benefits of antegrade perfusion are that it is more physiological and circulatory arrest can safely be extended to allow more complex aortic repairs to be done. The major risks are that you need to manipulate the aortic vessels and hence there could be a risk of vessel damage and there's a risk of air embolization. It also, because of numerous cannula in the surgical field, you could also reduce the surgical visibility. Now, there was a question, could we actually avoid circulatory arrest during aortic arch surgeries? So in 2011, a branch first technique was first described. Here what is done is that the body is perfused through the femoral cannula as well as through the right axillary artery. And then innominate artery is clamped, divided, and then the distal end is attached anastomosed to one of the branches of the trifurcated graft. And this graft is perfused via a side branch. Once this is done, then the end-to-end anastomosis of the left common carotid artery is done in a similar way. And then after this, the left subclavian artery is anastomosed. So we have seen that during this entire procedure, the brain is continuously being perfused by at least 2 of the 3 supraortic vessels. Using this technique, they reported very good outcomes, and they concluded that with this technique brings us closer to having outcomes similar to those from ascending aortic and aortic root procedures, which is very encouraging. Over the past 15 years, many meta-analyses have been published, but in January 2020, a network meta-analysis was published, which showed that compared to deep hypothermic arrest, both antegrade and retrograde perfusion significantly lowered the risk of stroke as well as mortality. However, there was no difference between any outcome when you compare antegrade or retrograde perfusion, be it stroke, mortality, respiratory, or renal complication. Also, no difference between unilateral and bilateral antegrade cerebral perfusion. However, compared to deep hypothermia, use of moderate hypothermia was associated with much better results. So with this, we understand that we need some perfusion strategy with some hypothermia. Now coming to the non-surgical neuroprotection strategies, which is mainly pharmacological. In a recent survey, it was found that nearly 83% of the cardiac anesthesiologists reported using some form of pharmacological protection, although they knew that there was no proven pharmacological regime which was protective. They mainly used drugs which reduce cerebral metabolism and oxygen consumption. Barbiturates were most commonly used, followed by propofol. However, they both failed to demonstrate any neuroprotective effect. Volatile anesthetics seem promising because of their preconditioning effect. However, they improve outcomes with the heart, but not yet with the brain. Steroids seemed interesting because they reduce the inflammatory response. There is reduction of cerebral edema, and they also have free radical scavenging properties. With all these, steroids seemed promising and showed possible neuroprotective effect, especially when they are used in high dose and when they are used sufficiently in advance. Although evidence for protection is weak, there is definite evidence that it could cause steroid-induced hyperglycemia if not treated aggressively, which it can cause ischemic neurological injury. Therefore, we need to be careful. So the existing evidence shows that pharmacological neuroprotection can only be used as a neuroprotective adjunct and not as a substitute to hypothermia. Few words on monitoring. Obviously, when the blood supply and metabolism of the brain are being manipulated, we need to monitor it. EEG is indicative of cerebral metabolism, and with hypothermia, it decreases. Electrocerebral silence indicates minimal cerebral activity, which could signal as the end point of cooling during hypothermia, but it is largely variable, and it requires really expertise to interpret something of these waveforms. So process EEG like this was used, but they failed to show any improved outcome. Transcranial Doppler measures the blood flow in the middle cerebral artery. It's a sensitive tool to detect emboli, and it can be instrumental in detecting adequate perfusion of the contralateral hemisphere, especially during the unilateral antegrade cerebral perfusion. However, it requires a sonographer with sufficient expertise, and its validity has not yet been proved. NIRS seem promising. It is easier and faster to perform compared to transcranial Doppler, and there have been reports that it was helpful in detecting cannula malposition or inadequacy of contralateral perfusion during unilateral antegrade perfusion. However, no major studies showed major benefits with respect to outcomes. Currently, there are no consensus on the acid-based management strategy, but most adult surgeons prefer alpha-stat management to preserve autoregulation and to decrease the embolic risk. So compared to intraoperative cardiac monitoring, cerebral monitoring is still suboptimal, especially during extreme conditions of cardiac arrest and cerebral perfusion. To summarize, I would like to say that neurological injury is a devastating complication of aortic surgery. And the outcomes in aortic surgery largely depend on three things. One is the cerebral temperature, next is the circulatory arrest time, and how well are you perfusing during this arrest time. So by understanding these concepts, we can formulate a strategy so that we get a patient with an intact postoperative neurological outcome. Thank you very much.
Thank you, all the speakers. Now it is time to invite Dr. Ashish Amartya from Kathmandu to give his impressions about this session on tissue protection.
Yeah. Good evening, ladies and gentlemen. Greetings from Kathmandu, Nepal. I'd like to thank Dr. Rajesh Arya and the entire team of IACTA for this opportunity and conducting this platform in a difficult time. I would like to congratulate all the speakers. Going with the first speaker regarding the post-operative pulmonary complications, she highlighted more on the intraoperative consequences and prevention that we can do for the pulmonary complication. But we need to think about the holistic approach regarding the rehabilitation, pain management, patient blood management, and the non-invasive ventilation as well. Regarding the second speaker, regarding the myocardial protection, he highlighted about the history of myocardial protection, the present schemes for the myocardial protection, as well as the future goals. The third speaker talking about the neuromonitoring in aortic surgery. He has highlighted on the DHCA, then again extending DHCA with the integrated cerebral protection and all the monitorings, which were all well said. So this is all I have to say now. I will hand over to Dr. Pravatiwari to take the audience question and open the house.
Thank you, Ashish. And we have a few questions from the audience. More so, I have a few for the Dr. Anandi. One speaker has actually, can we share all the speakers and the chairpersons, that screen, please? It is about the pressure-controlled ventilation. What about the role of psi? Means when you are doing a pressure-controlled ventilation and you are giving intermittent size. So Dr. Anandi, can you just tell us something about that? Dr. Anandi, please.
Dr. Anandi, you are muted, I think so. Everybody to unmute, please.
Can
unmute and stop and videos, and please, so that everybody is able to see all the chairpersons and the speakers, please.
Can you hear me now?
Window. Yeah, please, go ahead.
I don't think there is any difference between pressure control ventilation and volume control ventilation in terms of outcome. So the main important thing is you can either use a pressure control or a volume control as long as you limit your driving pressure to less than 16 centimeters of water. I think that is more important than the mode of ventilation that you are using. And as to the side, it is usually used in pressure control ventilation, and you can use psi, but I'm not sure whether it has been proved to be of benefit, although it improves oxygenation, but I'm not sure whether it improves outcome. I think there is a trial that is going on called the protection trial, the outcome of which we will know once it's published.
Dr. Deepa asks about that sometimes she had hypercapnia to the tune of around 50 in the post-operative period in cardiac surgical patients. So do you agree to that? Are you concerned about that?
Yes, I mean, as long as the pH is less than 7.2, I think we needn't worry too much about over-ventilating in terms of increasing the tidal volume too much. As long, I mean, I'm not sure whether the permissive hypercapnia is allowed in cardiac surgery, but it has been proved to be of benefit in ARDS as long as you limit your pH to less than 7.2. I think that should be the driving
Okay. And Dr. Gopi asked that what is the role of your MUF and PUF as far as the cardiac population is, pediatric cardiac population is concerned, to protect the lungs in the post-operative period? Probably you are offloading too much fluid.
In our institution, we routinely use MUF to, in all pediatric surgery patients. I don't do pediatric surgery, so I'm not the right person to comment on the,
Okay, Dr. Vaikar from Sri Lanka asks that means when you talked about this open lungs during cardiopulmonary bypass, that do you think that it is high PEEP is actually interfering with the surgeon, and that could be the reason?
High PEEP can not only interfere with the surgeon, but it can also cause variations in your hemodynamics. It can bring down your blood pressure also. So that could be the reason why there was no difference in the outcome. I can.
Okay, thank you. There is a question for Dr. Manoj. What about the role of adenosine in hypertrophied left ventricle and all? Dr. Manoj?
Yes, sir. Yes, sir. Adenosine, nowadays we are not using adenosine in left ventricular hypertrophy patient in our center, but previously we are using adenosine in that it arrests heart immediately. So that's why it reduces the requirement of myocardium, decreases the generation of the lactate and decreasing the ATP level in the heart. But in nowadays, we are using slightly hypothermic the patient, and we are routinely using hot shot in patients who are patient of pre-existing left ventricular hypertrophy.
All right, and I think one of our chairpersons, Dr. Dheeraj, added
can I say
that it's a retro versus antigrade if you combine together. So what's your opinion, Dr. Manoj?
We are
Dheeraj, let Manoj reply.
Yes.
We are infrequently doing retrograde cardioplegia. We are routinely using antigrade. When there is significant AR is there, then we can use this. Then there might be advantage of retrograde cardioplegia. So in my opinion, if there is no AR or we are not able to provide antigrade myocardial protection very well, then we can think about the retrograde cardioplegia.
Thank you. We have got one question, and that is the last question of this session to Dr. Sandeep. Sandeep?
Yes.
What is the role of sodium channel blockers in neuroprotection? I think Gopi again has placed this question.
Yes, sir. Basically, if they see the pathogenesis of ischemia, what happens is that when there is ischemia, there is a loss of ATP. So the sodium potassium ATPase channels stop functioning, and there is a rapid rise in the hydrogen ions, and which leads to next calcium release. So when we use the sodium channel blockers, so basically what we are doing is we are stabilizing the membranes. So as a membrane stabilizer, it helps. So things like Xylocard, they help by membrane stabilization. Also magnesium also acts by membrane stabilization.
So if I say you have to choose between magnesium and lignocaine or xylocaine, what will you choose?
So magnesium.
Magnesium, okay. Okay, thank you all. Thank you. I hope, because I don't find any other question. So I thank all the chairpersons and all the speakers and the organizers and our secretary of IACTA for a wonderful session on tissue protection. You people have done a wonderful job. So I hand over the mic to the organizers, please.
Thank you, Prabhat sir. Thank you all the chairpersons and speakers. And we'll be moving to the next session. And before that, you listen to this beautiful video.